All right. In this chapter, we're going to talk about respiratory emergencies. So basically, we have to be able to provide basic and select advanced emergency care and transportation based on assessment findings. Ill patient, so some anatomy and signs and symptoms of management of respiratory emergency, including those that affect uptake, for different management of different pulmonary diseases, pulmonary causes, some more pulmonary causes. Sorry. Dyspnea is the difficulty in breathing. It is a common complaint, and it can become common amongst many different other complaints. A lot of people will tell you they're having one complaint, but they're also having shortness of breath. So you keep medical problems in mind as you obtain history and perform your assessment and treat the symptoms, underlying problem, and sometimes anxiety that comes with patients being transported by us on the ambulance. Upper airway, all the airway structures above the level of the vocal cord. As you can see there, you got your pharynx, your mouth, the epiglottis, and the larynx. The gas exchange happens within the blood and the pulmonary circulation as it picks up the oxygen and releases the carbon dioxide. Here's a review of the AEMT of airways. Just remember that in pulmonary circulation, things are different. The oxygenated blood is carried from the heart to the lungs by the pulmonary arteries, but that's the circulation going back to the heart, and usually in normal circulation throughout the rest of the body, the arteries carry blood away from the heart, and it's oxygenated. The oxygenated blood going to the lungs back to the heart, and that's by the pulmonary veins. So then here's the circulation in the rest of the body. On the right side, you got that nasal cavity where you always think about a child having a disproportionately larger tongue in the airway versus the adult. Two processes that occur during is inspiration and expiration. Ventilation is the process of air moving in through and out of the lungs. The heart pumps oxygenated blood throughout the body, and carbon dioxide is exchanged for. So here's the tissues on the left side of the picture here, as you're looking at in picture A. So oxygen passes from the blood through the capillaries to the tissue cells. Carbon dioxide passes from the tissue cells through the capillaries to the body. In B, in the picture B, in the lungs, oxygen is picked up by the blood, and carbon dioxide is given. So in inspiration, stimulus to breathe comes from the respiratory center in the medulla. That is the involuntary control of the breathing originates in the brainstem. Impulses for automatic breathing can be overridden to a point, while voluntary control motor nerves of respiration are the phrenic and intercostal nerves. So during inspiration, the diaphragm and the intercostal muscles contract, thorax enlarges, and intrapulmonary pressure follows below the atmospheric pressure. So this is when air is pulled in and fills the lungs. The air pressure outside the thorax equals the pressure inside the thorax, and inhalation stops. So normal respiratory volume is 3,000 mL for an adult male and 2,300 mL for an adult female. Expiration has the chest expands, receptors send that signal to the apneustic center to inhibit inspiratory center, and expiration occurs. This helps prevent overexpansion of the lung. Expiration lasts twice as long as inspiration, and this is where you get your hair and pure reflex. So, with the overexpansion of the lung, normal expiration reserve volume is about 1,200 milliliters. Expiratory phase is short in a patient with tachypnea. Adequate ventilation, diffusion, and perfusion must occur for the body to receive nutrients and oxygen. Some complications interfering with oxygen intake could be upper and lower airway obstruction, chest wall impairment from trauma, and neurological control problems. Alveoli are made up of two types of cells. Type 1 allow for better gas exchange. Type 2 make new type 1 cells and produce that surfactant that help keep these alveoli open. Alveoli function best when partially inflated, and the surfactant reduces surface tension of the alveoli, making it easier for them to expand. Gas exchange interface conditions related to ventilatory and perfusion can prevent oxygen from reaching bloodstream. So people with pulmonary capillaries are narrow and normally allow red blood cells to pass through only in single file. So people with chronic lung disease make a surplus of red blood cells, making blood thicker. So this in some chronic lung diseases, chronic hypoxia generate that surplus of red blood cells over time. All right, a rise in arterial carbon dioxide levels lead to less efficient respiratory center, so it could result in chronic carbon dioxide retention. So the body may produce too much carbon dioxide. If the arterial carbon dioxide levels rise slowly to a normally high level and remain there, the respiratory factor center may work less efficiently. The failure of those centers to respond normally to a rise in arterial levels of carbon dioxide is a result of chronic carbon dioxide retention. So a condition called hypoxic drive is where the brain gradually accommodates high levels of carbon dioxide and uses a backup system to control breathing based on low levels of oxygen rather than high levels of carbon dioxide. The stimulus to breathe is the detection of low blood oxygen levels. If the arterial level of oxygen is raised, there is less stimulus to breathe. Giving too much oxygen to these patients may actually depress or stop respiration, but however, never withhold oxygen from these patients. You may just need not to use the aortic breather, even though we do not keep our patients long enough to kick in a hypoxic drive. Hopefully, we don't keep. So, in hyperventilation, we have an excess in carbon dioxide in the blood, and that results in respiratory acidosis. So this can occur if hyperventilation is not recognized, and carbon dioxide levels are directly related to the pH. All right, causes of hyperventilation: impaired lung function, impaired mechanics of breathing, impaired neuromuscular apparatus, and reduced respiratory. An arterial carbon dioxide falls below normal, may be indicative of life-threatening illnesses. Catnea with physiological demand for increased oxygen causes respiratory alkalosis. Okay, so hypo, you think acidotic, you think the acid is being stored and it's being in the body because we're not breathing it off. Hyper, we're breathing it off, so we're causing a base, and then we're having alkalosis. Dyspnea, shortness of breath, or breathing difficulty, can be several different causes. If the problem is severe and the brain is deprived of oxygen, the patient may not be alert to any kind of change. So the causes of dyspnea is air hunger, chest tightness. It is a common complaint with patients with cardiopulmonary diseases. So severe pain can cause the patient to experience rapid shallow breathing without pulmonary dysfunction. Infectious diseases may affect all parts of the airway, may cause dyspnea by obstructing airflow in the larger airways. It may impair exchange of gases between the alveoli and the capillary. All right, acute pulmonary edema is the accumulation of fluid in the lungs, decreases in gas exchange, severe dyspnea, and the fluid collects in the alveoli and lung tissues. So not all patients with pulmonary edema may have heart disease. So the left side of the heart cannot remove the blood from the lungs as fast as the right side delivers it. So you have left-sided failure, the fluid collects in the alveoli and the lung tissue. This may happen quickly or may take over time. Um, you may have some other causes without edema. Poisoning from smoke, toxic chemical fumes, traumatic injuries to the chest, exposure to high altitude. So, patients with pulmonary edema also present with dyspnea or orthopnea. That's decreased shortness of breath and standing, fatigue, reduced exercise capacity, and pulmonary crackles. Chronic obstructive pulmonary disease is a slow process that disrupts airways and alveoli, and cigarette smoking is the most common cause. The obstruction occurs in the bronchioles. The cilia are unable to remove excess mucus, creating a buildup. Chronic bronchitis is the result from overgrowth of the airway mucus glands and excess secretion of mucus blocking the airway. So patients have a chronic productive cough for at least 3 months per year or 2 or more consecutive years. Pneumonia develops when passages are consistently obstructed. Repeated episodes can lead to COPD. Emphysema is the most common form of COPD, characterized by the destruction of alveolar walls related to the destruction of pulmonary surfactants. Patients with acute COPD will complain of shortness of breath, will gradually increase in symptoms over a period of days. Exhale through the pursed lips, complain of chest tightness, and constant fatigue, and have a chest with a barrel-like appearance, which you see in this picture. So this is where the inflammation due to the mucus buildup in the bronchioles. Acute spasm of the bronchioles is excess mucus production and bronchial muscle spasms. It's a combination of bronchial spasms and mucus production in edema. So anaphylaxis is characterized by the airway swelling, dilation of blood vessels all over the body. It can cause respiratory distress, even lead to a coma and death. Most reactions occur within 30 minutes of exposure to the allergen itself. Spontaneous pneumothorax is accumulation of air in the pleural space. It may be partial or it could be a complete pneumonia. Trauma is the most common cause of a pneumothorax. And it may occur in patients with certain chronic lung infections, patients who are young and were born with weak areas of the lung, emphysema, asthma patients. Also, tall, thin, healthy males are also at risk because the lung doesn't develop as quick as the patient rises in height. Patients become acutely dyspneic and complain of pleural chest pain, so it's worse during breathing or with certain movements of the chest wall. The patients may be present with subcutaneous emphysema. That's a snap, crackle, pop, usually in the skin or just up under the skin. It usually occurs in the neck area down to the upper shoulders. And also, breath sounds are absent or decreased on the effect. Patients become acutely dyspneic and typically complain of pleuritic. You'll have a tracheal deviation is the right side with a spontaneous pneumothorax. Just try to always remember whichever way is deviating to. So if it's deviating to the left, the pneumo is going to be on the right side of the patient's chest. So pleural infusion is a collection of fluid outside the lung on one or both sides of the chest. The fluid may be from irritation, infection, or cancer, and it should be considered in patients with lung cancer and shortness of breath. You will hear decreased breath sounds over the region of the chest where fluid has moved the lung away from the chest wall. Patients usually feel better when they sit upright. and the definitive treatment is fluid removal. Pulmonary embolism or blood clot circulates through the venous system and travels into the pulmonary artery. It's caused by a clot formed in the leg of the vein, and it decreases or completely blocks blood flow. So, patient may also have damage to a pulmonary embolism may also occur if they have damage to the lining of the vessels, hypercoagulability, and blood flow in the lower extremity. So some risk factors include immobilized legs, recent surgeries. This is why you see those icon little stockings on their leg. But sometimes they also have to sit there with those leg things that help keep the blood flow if they're being immobilized for an amount of time. Pregnancy or oral contraceptives, infections, cancer, sickle cell, prolonged inactivity, and bedridden patients. Signs and symptoms: dyspnea, tachycardia, tachypnea, varying degrees of hypoxia, cyanosis, acute chest pain, and hemolysis. So, patients with dyspnea may also have a mechanical obstruction, so I always think about that in the upper airway. We usually think food, vomitus, or foreign, or the tongue itself blocking the airway. Environmental industrial exposures: pesticides, cleaning solutions, chemicals, chlorine, and carbon monoxide. So the amount damaged is largely depends on the water solubility of the toxic gas. So high water solubility gases causes swelling and irritation. Less water solubility gases causes pulmonary edema up to 24 hours. Cystic fibrosis is a genetic disorder that affects the lungs and the digestive system. Symptoms range from sinus congestion to wheezing and asthma-like complaints. Look for respiratory insufficiency, signs of respiratory infection, and intestinal blockages. So it also causes death in the childhood age patients. Cause of the chronic pneumonia. Age-related conditions such as bronchiolitis is inflammation of bronchioles due to viral infection. Could be RSV. Primarily affects the children younger than 2 years old. So it does create an infection in the lungs and breathing passages, and it is highly contagious. Asthma is rare in children younger than 1. Infant with first-time wheezing episode in late fall or winter likely has bronchiolitis. RSV, common cause of illness in young children. It creates an infection in the lungs and breathing passages, and it can cause pneumonia also. It is highly contagious. All right, the croup is inflammation or swelling of the pharynx, larynx, and trachea, secondary to an acute viral infection of the upper airway tract. Typically seen in children at ages 6 months to 3 years, and it's easily passed between children. It starts with a cold, cough, and low-grade fever that develops over 2 days. The hallmark signs are stridor and a still-like bark. So peak seasonal outbreaks in late fall and early winter, and it's rarely seen in adults. Often responds well to humidified oxygen. Epiglottitis is inflammation of the epiglottis caused by bacterial infection that produces severe swelling of the flap of the larynx. Predominant in children that may occur at any age, and its development of a childhood vaccine against influenza that dramatically decreased in the incidence of the disease. May completely obstruct the airway itself. Patient will look very sick, usually a strong offset. Patient will usually be in the tripod position and drooling. So sore throat, high fever, stridor, high pitch, inspiratory sound. May occur in adults or geriatric patients, especially with other issues such as diabetes, caused by different bacteria and viral organisms, and it can be potentially life-threatening. So, pneumonia is a ventilation disorder caused by an infection of the lung parenchyma. 8 leading causes of death in the United States. A group of specific infections, not a single disease. Very young children and the elderly are the ones that are at most risk. Presents has a localized infection in the lungs that may cause hardening of the alveoli. If left untreated, it can become systemic, leading to sepsis and septic shock. So, signs and symptoms: acute onset of fever, chills, productive cough with sputum, pleuritic, chest pain, and excessive mucus causing pulmonary consolidation. Pertussis is an airborne bacterial infection. Mostly affects children younger than 6 years. Highly contagious, pass through the droplet infection. Feverish with a whoop sound or on inspiration after a coughing attack. And cold-like symptoms, but coughing spells can last for more than a minute. And the child may turn red or purple. Airway obstructions, always consider a possibility of a foreign body when a young child becomes short of breath. Tonsil inflammation may partially occlude the airway. Dysfunction of the tracheostomy may create an upper airway obstruction. An obstruction may be in the lower airway below the vocal cords. Tracheal trauma, lung disease, mucus accumulation, smooth muscle spasms. Edema may present with a patient who has been exposed to a toxic chemicals or superheated air. Heart failure, heart muscles injured by heart attack or illness, results from pulmonary edema. Risk factors include hypertension, history of coronary artery disease. Signs and symptoms are difficulty breathing with exertion, sudden attack of respiratory distress, feeling suffocated or cold sweats and tachycardia. Wet lungs associated with pulmonary edema. Dry lungs are associated with COPD. Breath sounds are helpful but can also be confusing. Treat the patient, not the breath sound. So, when you're seeing size up, determine the number of patients, determine the nature of the illness, identify the need for specialized resources. In your primary assessment, recognize life threats and initiation of resuscitation takes priority. So, signs of life-threatening respiratory distress, severe cyanosis, absent or abnormal breath sounds, audible stridor, dyspnea, coughing, tachycardia, abdominal breathing, change in respiratory rate or rhythm, pylora or diaphoresis, and the use of accessory muscles in the tripod position. Primary surveys, note general impression of the patient, determine if the airway is open and clear, determine if the patient is breathing, and provide appropriate oxygenation. Always assess your pulse rate, rhythm, and character. If the patient is tachycardic or brady, it may indicate the patient may not be getting enough oxygen. Identifying your life threats in your patients, any problems with ABCs, poor initial general impression, autoimmune status, potential hyperperfusion or shock, chest pain associated with low blood pressure, severe pain anywhere, and excess bleeding. Patient is unstable and there's possible life threat, address the life threat and proceed with rapid transport. If the patient is stable and there are no life threats, you may decide to perform a thorough secondary assessment on scene after obtaining the patient's history. So assess the breath sounds long. Breath sounds is one of the most important vital signs of your patient if they are experiencing respiratory distress. So listen over the barrier of the chest, over the anterior part. The diaphragm of the stethoscope must be in firm contact with the skin, and bring your patient to a sitting position. And there are some different areas that you can listen over the anterior and posterior areas of the patient. Determine whether the breath sounds are normal or abnormal. Vesical breath sounds corruption of air movement In and out of the alveoli. Bronchial breath sounds represent air movement through the bronchia. So the avid, well, listen to a full respiratory cycle when you are listening. Crackles or fine crackling sounds of air trying to pass through the fluid in the alveoli. Bronchi is a lower pitched sound caused by secretions or mucus in the larger airway. Stridor is a high pitched sound heard over inspiration. Air tries to pass through an obstruction in the upper airway. Wheezing is high-pitched whistling sound typically heard on expiration that indicates constriction and or inflammation in the bronchia. Pleural friction rub is the squeaking or grating sound that occurs when the pleural linings rub together. Snoring sound is a partial upper airway obstruction. So make sure you get a sample, especially if, from a family of bystanders. If the patient can't give it to you, try to limit questions to pertinent ones like general state of health, childhood and adult diseases, recent surgeries, or hospitalization. Any kind of traumatic injuries may occur and any kind of chest pain they may have. Ask about any previous episodes, medication, allergies, or current medications that may be taken. Find out what the patient has already done for the breathing problem. Try to pay close attention to the medications the patient is currently taking. Use the QRSTI mnemonic. Determine the specifics of pain and obtain information from the breathing problem. Chronic lower obstructions makes it difficult for patients to breathe deeply enough to clear the lungs. So it can also make it difficult for patients that have a new infection of the lungs. And a lot of times this occurs with COPD, and the arterial oxygen level may fall rapidly. Patients with COPD usually have a long history of dyspnea and a sudden increase in the shortness of breath. It's rarely a history of chest pain. Pulse is rapid, occasionally irregular. Pay attention to the respiration. Patients with asthma may have different triggers. Try to determine what may have triggered the attack this time. Secondary assessment, a more in-depth assessment of the body systems. Address the specific chief complaint. Perform and identify any training for life threats. A change in mental status is one of the early signs of respiratory inadequacy and indicates a lack of perfusion of the brain. Look for overall symmetry of the chest, adequate rise and fall of the chest, and evidence of retractions and or accessory muscle use. Check the respiratory status. A slowing respiratory rate with a unimproved conditions is just physical exhaustion and impending respiratory failure. So look for increased work or breathing. So these patients look for your chief complaint, perform and treat underlying life threats. A lot of these patients will become sleepy. A lot of times is what I see. They'll kind of sit over, and you'll be able to wake them right up. Okay. And then you can start asking these patients questions, and you'll be like, are you really feeling tired of breathing? And they will tell you yes. This is a indication of that impending respiratory therapy. Not therapy. Impending respiratory failure. So when this happens, you need to be ready to actually intubate or whatever you may deem necessary to take over that patient's airway. Because a lot of times these patients will just give up. All right, assess your circulation, check for signs of trauma or retractions in the chest, obtain vital signs, and use monitoring devices if necessary. Your secondary system, your secondary assessment. Um, Reassess your primary survey. Monitor the patient's breathing, reassess circulation. Determine if there have been any changes in the patient's conditions. Confirm the adequacy of intervention and patient status. Be prepared to assist ventilation with bag mask device. Monitor your skin color and temperature, and reassess and record vital signs. So if they're stable, if they're stable at 15 minutes, if they're unstable every 5 minutes. So, oxygen saturation, keep it above 94%. So psychological support also, you may need to coach these patients down as far as if they're hyperventilating. That way they will get that big good exchange of O2 and CO2. You may need to remove some constricted clothing. Try not to lay these patients down supine, and do not make the person walk if at all possible. If you do, make sure you're standing there beside them because they could go unresponsible on you very quickly. So provide supplemental O2, administer oxygen and concentrations necessary to be effective. Pulse ox is a useful guide. 2, oxygenation. Safety administer oxygen concentration less than 50% to almost anyone. Oxygen saturation is 100%. You need to try to avoid that, because you could possibly over-oxygenate some patients, and this could cause other problems. Administering a Barker dilator. Patients who do not have Barker's spasms usually benefit only slightly from aerosol bronchodilators. A bronchodilator are of little value in treating conditions such as pneumonia, pulmonary edema, and heart disease. Respiratory medications. Most common medications used for dyspnea are inhaled beta agonists. Secondary bronchoconstriction could be reversed with a bronchodilator. Some common side effects: the inhaled tachycardia, nervousness, and muscle tremor. So preventable Ventolin and Berthane. So they are used to help relax the smooth muscles of the bronchioles in the lungs. Then this makes the bronchiole larger. They are pretty fast acting. Aerosol therapy nebulizers deliver liquid medication as a fine mist to generate optimal particle size. Most nebulizers need to have oxygen flow of at least 6 liters per minute. So aerosol therapy, a nebulizer can be attached to a mouthpiece, face mask, or a tracheostomy collar, or held in front of the patient's face. Middle dose inhalers direct medication through the mouth and into the lungs, and is achieving the proper technique requires constant reinforcement. Patients should try to inhale the medication deeply, then hold their breath for a few seconds. Contraindications include patient is unable to help coordinate inhalation. The middle dose inhaler is not prescribed for this patient, and the patient has already met the maximum prescribed dose, or the medication may be expired altogether. Dry to powder inhalers, reasonable, convenient, and easier to use, rarely used during emergency care. Always consider your fluid balance. Give a fluid bolus to younger patients and older patients or patients with cardiac dysfunction, and administering too much fluid could cause pulmonary edema. So a lot of these times these patients are hypertensive with a slow heart rate anyway. Don't go giving them a bunch of fluid when you see signs and symptoms of cardiac dysfunction, i.e. left-sided heart failure or right-sided heart failure, either one, when they have lower edema. Support and or assist in ventilation if the patient becomes fatigued breathing might need to be supported by more aggressively. Some patients may simply require bag mask ventilation for a short period of time. Gastric distension and vomiting can occur from over-aggressive ventilation. All right, CPAP is used to treat obstructive sleep apnea or treat respiratory failure. Many people with obstructive respiratory failure or sleep apnea wear these things at night. It delivers oxygen continuously through a mask secured to the patient's face by some type of strap. So the administered CPAP increases pressure to the chest. You need to be vigilant about monitoring the gas supply because it could cause a simple pneumothorax to develop. So you don't try to struggle with a patient who is unwilling to use the mask. Bilateral positive airway pressure is once pressure can be delivered during inspiration and a different pressure can be delivered during exhalation. It is more comfortable. It causes a pressure variation in the chest, which allows for more normal blood flow and more complex and expensive. Upper and lower airway diseases, patients present with signs of severe respiratory impairment. Chief complaint is typically dyspnea, cough, or nocturnal dyspnea. A lot of these patients present with one or two word sentences. They're not able to speak due to the dyspnea. Obtain a thorough history, including personal or family history. Determine whether the patient has an acute exposure to pulmonary irritant or previous single episode. Wheezing may be present. Use a peak flow meter to establish the baseline expiratory airflow if you have that available in your area. Consider calling early if the paramedic backup patient is in severe distress. Monitor the airway, apply high flow to and assist ventilation if needed. Establish an IV and provide circulatory support. Assess patient with a metered dose inhaler as needed and continue monitoring. Acute pulmonary edema may be associated with cardiac disease or direct lung damage. Initial high oxygen, high flow. If necessary, carefully suction any secretions from the airway. Place the patient in a position of comfort and provide assisted ventilation if continuous. CPAP has been proven to be beneficial with pulmonary edema patients. So, depending on your local policies and procedures, you may be able to use it at the advanced EMT level. Get your IV access. Please be careful about flow rates. With IV access and fluid administration, a lot of times we just do the saline off on these. All right, aspiration, inhalation, or anything other than gases. Most of the time it's food stuff, especially with gastric feeding G2 patients associated with high mortality rate. When treating patients at risk for aspiration or who have aspirated, avoid gastric distension when ventilating. Aggressively monitor the patient's ability to protect his or her own airway. Aggressively treat aspiration with suction and airway control if the previous steps fail. A lot of times you can suction these patients and it does. All right, COPD patients often find breathing difficulty while laying down. Assist with a prescribed inhaler if there is one. And a lot of these patients do overuse their inhaler. So watch for the side effects, the tachypnea, the nervousness, and the jitteriness. Transport promptly to, as possible, to the emergency department, allowing the patient to sit upright in that most comfortable position. The auto PEEP is complete exhalation must be allowed before the next breath is delivered. If you have this device in your area, it can lead to a pneumo and cardiac arrest. All right, asthma assessment of the patient is critical, often a recurring pathological condition. If possible, ask family members to describe the patient's asthma, three components of asthma are bronchial spasms, airway edema, and increased mucus production. Pulse rate will be normal or elevated, blood pressure may be slightly elevated, and respirations will be increased. Ask the patient or the family questions about when and how the symptoms began, and be prepared to such and administer oxygen. A lot of times you just need to know what triggered the asthma, and how long they've actually been experiencing those symptoms, especially those acute symptoms. A lot of times these patients try to treat themselves at home, and then they wait too long to actually get help, and you're on the backside trying to correct what's going on. So use slow, gentle breaths when ventilating. Emergency care of a child, same as an adult. If you must assist ventilation, do it slowly. Status asthmaticus is a dire medical condition. Chest wall will be maximally hyperinflated. Breath sounds or wheezes may be entirely inaudible because air movement is none, pretty much. Aggressive airway management, oxygen administration, prompt transport are essential. Anaphylactic reactions will remove the offending agent, maintain the airway, apply and administer supplemental O2, assess breathing as needed, and epinephrine is the treatment of choice. Okay, spontaneous pneumothorax, manage your ABCs, provide airway and ventilatory support, be alert for signs of tension pneumothorax, and consider IV initiation if severe symptoms are present. Place the patient in position of comfort transport. Think about calling for a paramedic. If it develops into a tension pneumothorax, paramedics can actually do a needle decompression to correct it. Also, with anaphylactic reactions and that acute respiratory effect, yes, epinephrine is the drug of choice. Don't forget about albuterol too to help keep those alveoli open because they have experienced a acute destruction of some of them. So, in your IV action. Hyperventilation can be caused by life-threatening illnesses and panic attack. Determination of which should not be made outside of the hospital. Give supplemental oxygen and transport. Intervention, circulatory support, and pharmacological interventions are rarely required. And provide psychological support for the anxiety-related hyperventilation. So you have to coach them down a lot of times, and just tell them that you're going to give them help, and you're there to help them at the current. Obstruction of the airway, upper obstruction may be partial or complete. The patient can talk or breathe, provide supplemental oxygen and transport. Remove obstructed body according to basic life support guidelines, and administer your O2. Environmental and industrial exposure. Industrial sites often have their own medical fire hazmat teams. So once the patient is decontaminated, gather information on the substance and cause of the ditch. Assess your patient. Pay special attention to the lung sound. Blood coming from the airway is an ominous sign. Provide 100% O2 or assist the ventilation if necessary. If the airway is compromised, aggressive airway management may be required. Bronchiolitis treatment is entirely supportive. Provide supplemental O2 and be prepared to use a BBM. Try to contact for permit for endotracheal intubation or in the state of North Carolina. Be prepared to intubate yourself. So respiratory, RSV. Look for signs of dehydration, treat airway and breathing problems. The crew also responds well to humidified oxygen. Allow the patient to assume position of comfort and avoid agitating these patients. Administer nebulized epi is dictated by local protocol and transport quickly. Echinococcitis, be gentle to children and try not to do anything to make him or her cry. Keep the patient in a position of comfort. Give high flows too. Do not put anything to the patient's mouth. For adult patients, focus on maintaining pain in the airway. Pneumonia, monitor your ABCs, provide high flow to and ventilatory support as needed. Administration of IV fluids may help. If the patient has a high fever, try to cool them and transport. Pertussis, some infants and young children should be treated in the hospital. So watch for signs of dehydration. This can lead to pneumonia itself. Children may vomit or not want to eat or drink. Watch for signs of dehydration. Give oxygen by the most appropriate means. All right, shut the airway in children. Clear the airway, provide oxygen transport. Heart failure, high blood pressure, and low cardiac output often trigger this sudden flash pulmonary edema. The patient's pulse will be tacky. The patient may have hypertension early, followed by deterioration to hypotension, and is a light finding itself. Treatment consists of airway, ventilatory, and circulatory support, and consider your CPAP. Tracheostomy dysfunction. Children with chronic pulmonary conditions may use home ventilators connected by tracheostomy too. There's many different complications. A lot of times these patients, the caregiver is supposed to be trained properly on these ventilators at home. Sometimes they are, sometimes they're not. If you don't feel comfortable with that airway, with that ventilator, just take it off and you just bag these patients on the way to the hospital. Okay, once the obstruction is clear, oxygenate the patient and treat based on presentation. Epidemic and pandemic considerations. Epidemic occurs when new cases of a disease occur in a human population substantially exceeding what is expected based on recent experience. A pandemic is an outbreak that occurs on a global scale. So many potential diseases can be passed by the respiratory route. The flu is one, so be very, very careful because you could have an outbreak of the flu to a large area. Always wear your PPT. Maintain your vaccination. Stay up to date on the latest CDC recommendations. Wear a HEPA respirator during aerosol generating procedures. A little bit later, regulations about Benadryl. Pleural infusion treatment is removal of fluid collected outside the lungs, provide oxygen and other routine support measures. Pulmonary embolisms, manage airway, provide high flow too. Initiate CPR for pulse less than active patients. Establish an IV of isotonic crystalloid solution. And most other interventions are just supportive. Expect their asthma and upper respiratory infection. So patients that are in status asthmaticus, it is a severe prolonged attack. It cannot be resolved with conventional treatment, and the reason can be heard when asthma patients exhale.